Thank you so much, Professor Lin. So first of all, any of you perform PVE regularly in your practice? Okay, yeah. So it's impossible that we teach how to do the PVE. But today I want to talk about the concept and also the growing concept of PVE. This era is very more important of the PVE because the reason is with the systemic therapy more powerful. The local regional treatment alone is not enough for the patient. So the only way we can get better than systemic treatment is we convert the patient for curative treatment. So this is the reason why we have to do more PVE in this era, and we have to cooperate more with the surgeon in order to get better survival than systemic treatment. And when you talk about the resection, one of the things I learned from in Thailand is that when I talk to my team, when we speak about resection, we only speak about the anatomical resection. But the other surgeon, when they say that, oh, this is resectable, but they just only do that resection with minimal like safety margin. And this is unacceptable because if you do non-anatomical resection, the rate of recurrence and survival is poorer than anatomical resection. For example, if we find the tumor, small tumor like this, but close to the right portal pedicle, this is 10 years ago that we do tests and then PVE and then right hepatectomy. And 10 years later, he just had a small recurrence on the left lobe. And these 10 years, he has a normal life. He cancer-free, he worry-free, he start his family, and he's a university professor, and he make a socio-economic impact on patients, on Thailand, and also the people around him. So this is the powerful of curative treatment, which we should offer patient the best treatment option available. And the choices of the FLR augmentation, PVE is the most standardized one, but we will go to the liver venous deprivation more and more in the next 5 years from now. And the other thing is about Y90 radioembolization, which you can control tumor and also get FLR augmentation at the same time. About the PVE, this is just redirect the portal flow from the non-FLR to the FLR side and let the liver grow inside your body as been described over 20 years. And usually I perform ipsilateral approach in order to avoid injury to the ipsilateral to the FLR portal vein vascular. Injury may cause the precluding subsequent surgery. So the rate of hypertrophy usually within 2 to 4 weeks, and this is the time you evaluate your volume, and surgeon might repeat the ICG 15 as well, especially in cirrhotic patient for evaluate the function of the liver cells. And this is the scheme that we all know that only volume doesn't matter, also the function of hepatocyte as well. The rule is 20, 30, 40, and with some high-risk surgery, especially when you have the bile reconstruction or vascular reconstruction, at least they need 50% of an FLR volume. And also diabetes patient and heavily treated with chemotherapy before will affect the FLR hypertrophy rate and also the ability to grow of the remnant liver. The techniques, 10 years is hardly to standardize the technique of the PVE, but the safest way is you go ipsilateral approach and then avoid the injury to an FLR. About the embolic material, it's been discussed for like years. We can use any before this we can use any gel foam, glue, PVA, or coil or vascular plug. But here comes in 2021, there is the best FLR trials that prove glue is the best embolic material for PVE, which provide the greater and the faster FLR augmentation effects. So it took us more than 10 or 15 years to standardize the techniques for PVE and make an evidence. So it's pretty hard to standardize the venous procedure in my point of view. But our data in our center, we've been using glue from the beginning, and our success rate is about 96%. The tumor that we apply PVE is not only HCC but also cholangiocarcinoma and colorectal metastasis. And today I will talk how we select the patient and what is the strategy of treatment planning for each patient. Because of each tumor has different nature and also the sequence of treatment is different. So for HCC, you need to do tests first if the tumor is quite large, and you have to control the tumor at least 1 to 2 months before the FLR is ready to be resected, and then PVE and then hepatectomy. So if you have small tumor, it is okay if you go to PVE first step. But if you have a large tumor and you need tumor control, then you have to apply TACE first. And the aim of TACE, mostly it is palliative. But if you apply TACE plus PVE, this is curative intent, which means that is any complication from TACE, especially liver decompensation, is unacceptable. Because this group of patients, you meant to give him the curative at the beginning. So if you are afraid of liver deterioration because of the TACE, you must convert the patient to Y90 or systemic treatment or something else, because you don't want to make him liver fail before getting resection. So you have to be very selective who you can test and PVE. If you cannot test safely, then apply other means for conversion therapy. This is my first rule. And then the sequence is that I do tests, and then maybe 2 to 4 weeks later, I do PVE. And then about a month or two later, we will reevaluate for the volume, and then the surgeon will take the patient for liver resection. And this is how we can get the FLR augmentation after the treatment. And usually when we do PVE, the surgeon will do right hepatectomy or more than that. And this is an example. This is quite extreme case that we have two large tumor. One is 14 centimeters on the right lobe, and another one 7 centimeters in the segment 4B. And his liver function is intact. So by that time, it's 2021, the patient cannot afford any systemic treatment like immunotherapy. So we give him a chance of curative resection, and he okay with the risk of the procedure. We did test for him twice, and then PVE, and then the patient underwent right sectionectomy, and now he is cancer-free for more than 4 years. So this is how we convert the originally inoperable patient step by step and convert him to curative treatment. This cannot be done successfully for every patient, but at least if you have intention to treat, then you follow your steps, and if succeeds, then the patient can have the long-term survival. The other tumor I want to tell you the story about is the cholangiocarcinoma. And Thailand's cholangiocarcinoma is different from the rest of the world, because we have the prevalence of the liver fluke infection. Most of our cholangiocarcinoma is perihilar tumor, like 90% of them. We have only little intrahepatic cholangiocarcinoma. So the resection of the perihilar tumor is much more challenging, and the prognosis of our cholangiocarcinoma is very poor. We can have only at less than 3 to 6 months survival after the diagnosis. And the only way to get the patient at least 3 years survival is to have the patient resected. And this is quite challenging because we have to start with the biliary drainage. Usually the patient may come with the obstructive jaundice or cholangitis, starting with bilirubin level over 20. First, we need to drain and make sure there is no infection in the liver, and then if we can drain adequately, TB less than 5, then we schedule the patient for PVE. And then if there is no tumor progression or extrahepatic metastasis, then the patient can have the resection. And our rule is that about 5, actually about 6 or 7, then we start scheduling the patient for PVE. And by the time the patient admit in the hospital, usually the TBL less than 5, and then we can safely perform PVE. You don't have to wait until bilirubin level is normal before scheduling for PVE. It is safe, just over 5 is okay. And then during that time, if the patient has uncontrolled cholangitis, you need to drain at least FLR. But if uncontrolled cholangitis, maybe you need to drain the whole liver in order to get away of the infection. And then the parenchymal volume for cholangiocarcinoma, mostly my surgeon wants more than 50% because they usually have to do bile duct resection or vascular reconstruction related to perihilar tumor resection. So that's why we need much more liver volume than the other kind of tumor. So this is even much more challenging for us to create that big FLR hypertrophy. And because of the before surgery, you have to wait until TBL less than 2. This is a quite common rule for our team. Before the patient go to surgery, less than 2 of bilirubin level. And if you look down at our details of the PVE for cholangiocarcinoma, you can see that it's quite complex. Like per se, if you want to do extended right hepatectomy, you have to do right portal vein embolization plus minus segment 4 embolization. And if you want to do left extended hepatectomy, we have to do left portal vein embolization plus anterior right portal vein embolization. So this is quite non-traditional way of performing portal vein embolization. So we have to communicate closely with the surgeon team. What kind of operation do you have in your mind for this patient, and which branch of portal vein would you like me to embolize for the patient? So the extent of PV embolization is performed according to the surgical plan precisely. And the other thing is that the success rate of the cholangiocarcinoma resection after PVE is lower than the other kind of tumor. If we look overall, success rate is about 67%, but cholangiocarcinoma alone is only 53%. And this is the segment 4 embolization. Sometimes you have only one branch, segment 4, but sometimes you have like many branches like this, so it's much more challenging technically. And sometimes you already have the vascular occlusion from the tumor involvement, so you have to plan your embolization according to the pre-existing vascular anatomy and variation as well. Overall, we can have the resectable rate a little less than 60% for cholangiocarcinoma after drainage and PVE. But when you compare the median overall survival, the group that can undergo surgery is way higher, more than double survival outcome when compared to the non-surgical group in our center. The last one is about the colorectal liver metastasis. Our strategy of applying PVE is that we clear the first stage on the left side, we do right PVE, and then we do second stage right hepatectomy. This is we call two-stage hepatectomy, which can provide like 5 years survival, like around 30 to 60% of the patient. And first we induction with chemotherapy, and then if the potentially resectable, then we start the first stage, even with the resection or ablation, and then we do PVE. And then if there's no progression, the surgeon will take the patient for the right hepatectomy. And this is the picture how we work together, surgeon and also IR. So sometimes we have to do double second stage twice, which means we clear the first time and then there's new lesion, we clear the second time before bring the patient for PVE. So this is multi-step treatment. And for example, multiple tumor like this, we do wet resection for all lesion in the left lobe, and then we do right PVE. And then the patient can have resection and have OS 5 years without any hepatic recurrence. So this is the only way you can provide long-term survival for multiple bilobar liver metastasis. And as I say, not 100% of the patient can follow these treatment steps. We can complete the second stage about less than half of the patient in my center, but our intention to treat from the beginning is pretty high. And the baseline follow-up imaging is very important. I recommend that you use the Primoris EOB MRI because you need to count every small nodules or new lesion or disappearing nodules. So Primoris MRI will change your planning of the treatment about 1/3 of the patient based on this trial. So if you have an eye on ablation and resection in the multiple colorectal metastasis, I advise you to use the EOB MRI as a follow-up imaging, and it's very important. And let's just touch a bit about the liver venous deprivation, which I think is more powerful than PVE, has been proved in the literature. And we have to focus more because some of the patients cannot undergo surgery because not enough FLR after PVE. But the technique is more challenging. We can approach from percutaneous, transjugular, or transfemoral. And we have another at least 5 years to standardize the hepatic venous embolization. To conclude my talk, like each tumor has a different story and different steps of the treatment, but we can provide anatomical resection and long-term survival by applying PVE into any liver tumor. And this is the way that we can stay better than systemic treatment nowadays. Thank you.